Respected Chairperson and learned audience, Assalamu alaikum. I am Dr. Mohammad Kalim Uddin, presenting OCT-guided Intravascular Lithotripsy of calcified vessel, first time in Bangladesh, the National Heart Foundation Hospital and Research Institute. This case was done by Professor Fuzilatunisa Malik, madam, on 9 January, and I assisted these cases. The 60 years male presented with hypertension, chronic coronary syndrome, regional wall motion abnormality with 55%, and coronary angiography revealed non-dominant vessel with free of significant disease and left main to LED highly calcified, visualized by fluoroscopy, and angiography done by radial route in another center. LED highly calcified and severely stenosis in its proximal segment starting from its origin, and LCX dominant vessel and significant calcified stenosis in its proximal segment. We took EVO catheter 3.57 French by radial route and calcified tapered left main with stenosis involving the origin of the LED and NH6. Left main to LED wired with the support of coronary microcatheter, and then predilation done with 3 into 12 mm non-compliant balloon to make passage to deliver IVL balloon catheter. Subsequently, 4 cycles of shockwave delivered with 3 into 12 mm IVL balloon in left main to LED calcified portion, and each shockwave duration was 10 seconds and balloon inflation pressure was 4 and 6 atmosphere. ECG during shockwave, and just immediate after calcium debulking with the IVL catheter, and then 3 into 38 mm drug-eluting stent deployed in left main ostium to LED, and post-dilation done with 4 into 12 mm non-compliant balloon at left main portion 20 atmosphere and LED portion at 18 and 20 atmosphere with 3.5 into 15 mm non-compliant balloon. And left main to LED nicely vascularized. And then L6 rewired through the stent start and OCT run taken from L6 to left main coronary artery. L6 is severely stenosis with junk of calcium in its proximal segment. There is calcium. And then 2 cycles shockwave delivered with the same balloon in a calcified L6 portion with at 4 and 6 atmosphere. And again OCT run taken to see the result of IVL in L6 and found calcification is nicely fractured. This nicely fractured calcium, and then 3 into 5 into 28 mm drug-eluting stent deployed in left main to L6 by Coulomb technique, and after POT LED rewired and subsequent balloon dilation followed by kissing balloon inflation done, and image showing that dissection occurred in distal L6 after distal edge of stent, and another 3 into 12 mm drug-eluting stent taken for covering distal edge dissection of L6. Report done with 4.5 into 6 mm non-compliant balloon at 16 atmosphere at left main portion, and this is final result. And OCT shows left main to LED is nicely apposed stent and well expanded, no edge dissection. And coronary calcification is reported in 18 to 31% of percutaneous coronary intervention, and available plug modifying device rely on tissue compression or debulking with the intention of fractioning calcium and facilitating optimal stent deployment. In contrast, coronary intravascular lithotripsy devices unfocused circumferential pulsatile mechanical energy to safely disrupt the calcium within the target lesion. And there are disrupt CAT 1 study, 2 study, second study, and third study showed that there is high rates of procedural success with lower rate of angiographic and clinical procedure completion, and 1 year follow-up from CAT 3 study recently published 2022 that treatment IVL treatment prior to coronary stent implantation is severely calcified lesion was associated with low 1-year rate MACE, and ischemia-driven target lesion revascularization was 6% and stent thrombosis 1.1%. This is IVL system. It consists of generator, connector, cable, and push button. And a catheter consists of a lithotripsy emitter, and is produced by a bubble inside the balloon, rapidly collapsing and expanding bubble, and this gives pulsatile unfocused circumferential pulsatile mechanical energy into the vessel. IVL uses acoustic Shockwave delivered through a semi-compliant balloon inflated at only 4 atmosphere in comparison to non-compliant conventional balloon. And IVL fracture both superficial and deep calcium in situ and minimize risk for vascular complication. So take-home message is in patient with severe calcified lesion who require revascular IVL before stent implantation can be performed safely and allow a rate of completion and with high procedural success. The angiographic and OCT findings support the potential of this new technology to impact clinical outcomes. Thank you from our cath lab team.